Thank you all for taking time off to join us in this morning's seminar on pelvic floor disorders. I'm Dr. Chua Hong Liang. I'm a senior consultant urogynecologist at the KK Women's and Children's Hospital. Pelvic floor disorders are common in our population. The incidence of pelvic floor disorders is set to increase as our population ages. Women are more affected than men. In one local study this year, it was estimated that the prevalence of pelvic floor disorders is as high as 60%. Common clinical presentations of pelvic floor dysfunction include pelvic organ prolapse, urinary incontinence, fecal incontinence, difficulty with bladder and bowel emptying. And quite often patients can have a combination of the above described presentations. Depending on the complexity of the condition, joint management by different specialists may be needed. To better serve our patients with pelvic floor conditions, the SingHealth Pelvic Floor Disorder Center was set up this year to provide integrated multidisciplinary care to this group of patients. Our center was officially launched by our Health Minister, Mr. Ong Li Kang, on the 4th of October at KK Women's and Children's Hospital. Our medical team include gynecologists, urologists, colorectal surgeons, physiotherapists, nursing, and allied health specialists. Patients with complex pelvic floor conditions can have seamless assessment and treatment carried out jointly by our specialists in the same visit. Today's seminar is brought to you by the specialists from our center, and the seminar will cover the different aspects of pelvic floor dysfunction. I hope this seminar will provide you with a better understanding of the condition. Next, I'll hand over this session to our seminar moderator, Dr. Sherilyn Foo. Dr. Sherilyn Foo, can you take over, please?
Hi. Good morning, one and all. Thank you very much for attending the seminar this Saturday morning. It is my pleasure to introduce Dr. Tan Yin Ru, our first speaker, who is an associate consultant in urogynecology at the KK Women's and Children's Hospital. She'll be speaking to us on pelvic organ prolapse. Am I at risk and what should I do? Dr. Tan, please.
Thank you, Dr. Fu, for the kind introduction. I'm Dr. Tan Yin Ru, Associate Consultant from the Department of Urogynecology at the KK Women's and Children's Hospital. And my topic for today is pelvic organ prolapse. Am I at risk and what should I do? I will be talking briefly about the pelvic floor and pelvic floor disorders before going on to pelvic organ prolapse. I will be going through some of the risk factors for pelvic organ prolapse, the assessment and management options, as well as a bit about what you can do to protect your pelvic floor and reduce the risk of pelvic organ prolapse. So many of us have heard of the pelvic floor, but what exactly is the pelvic floor? It is a sheet of muscles and connective tissues from the pubic bone over here to the tailbone. And what it does is it supports important structures in the pelvis, such as the bladder, the uterus, as well as the bowels. It also controls the passage of your urine, gas, and stool, and it contracts when you cough, when you sneeze, and when you strain, and helps to prevent the involuntary leakage of urine. Pelvic floor disorders are due to weakness of the pelvic floor support structures, and it can include conditions such as pelvic organ prolapse, urinary problems, as well as fecal or flatus incontinence. I will be focusing my talk mainly on pelvic organ prolapse today, while the other conditions will be addressed by the other speakers. So what is pelvic organ prolapse? Pelvic organ prolapse refers to the bulging of one or more pelvic organs into or out of the vagina. It occurs when the muscles and connective tissues that support your pelvic organs become weakened. A prolapse may occur in the front wall of the vagina, as you can see over here, where the bladder is prolapsing into the vagina from the front wall of the vagina. It can also occur at the back wall of the vagina, where the intestines prolapse into the vagina from the back wall of the vagina. There can also be a prolapse of the uterus into the vagina or out of the vagina. Many women have prolapse in more than one compartment at the same time. Here are some of the risk factors for pelvic organ prolapse. Pregnancy and childbirth are considered to be major factors leading to weakening of the pelvic floor. Furthermore, aging and menopause can also further weaken the pelvic floor support structures. There are some conditions which put excessive pressure on the pelvic floor, such as obesity, chronic cough or smoking, chronic constipation, as well as heavy lifting. These are some risk factors which may increase your risk of pelvic organ prolapse. So what are some symptoms that you may experience if you have a prolapse? Many women with a prolapse may feel a heavy or dragging feeling down below, or they may even feel a lump or something coming down or out of the vagina. These symptoms are usually worse with prolonged standing or at the end of the day. Pelvic organ prolapse affects around 50% of women in their lifetime. Many women have mild symptoms, but there are some women with more severe prolapses which may affect their daily life. It is important to note that not every patient with a prolapse needs surgery, and around 10% of women with pelvic organ prolapse have surgery. It is also important to take note that pelvic organ prolapse is a benign condition, but it may result in bothersome symptoms. It can result in discomfort. It may affect bladder function, bowel, and sexual function. In more serious cases, a prolapse may also result in ulcers, bleeding, and infection. Sometimes the prolapse may also obstruct the flow of your urine, which may cause backflow effects and rarely affect the kidney function. There is also a risk of recurrent urinary tract infection, and there's a risk of discomfort during sex. If the bowels are involved, patients may also have difficulties in passing motion or have the sensation of incomplete emptying. Therefore, prolapse may affect a woman's quality of life. So what should you do if you feel that you have prolapse symptoms? First of all, you should see your doctor for assessment of your symptoms, risk factors, your history, as well as the severity of your prolapse. An examination will be performed to examine and assess the severity of your prolapse. A pap smear, urine test, and ultrasound scans of your pelvis and your kidneys and bladder may also be arranged depending on your condition. And based on the assessment, treatment options will be offered. Going on to some of the treatment options available for prolapse. Treatment options include non-surgical and surgical options. Non-surgical options include observation, pelvic floor exercises, or pessaries. And there are various types of surgeries which can be performed for treatment of pelvic organ prolapse. So there are different treatment options available to suit your different needs. First, let's talk about conservative management. Some women may have minimal symptoms and the prolapse may not be affecting them that greatly. So they choose conservative management. But if you have been diagnosed with a prolapse, it is advisable that you avoid heavy lifting, avoid chronic constipation or chronic straining, as these may cause your prolapse to worsen. Also, it is advisable to lose weight if you are overweight and stop smoking. Going on to pelvic floor exercises. Pelvic floor exercises, also known as Kegel's exercises, is another non-surgical method to strengthen your pelvic floor. And exercising your weakened pelvic floor muscles may help to improve or prevent the worsening of early stage prolapse. Pelvic floor muscles may also be supervised by a trained physiotherapist. Similar to any other exercise, pelvic floor exercises require time, they require the proper technique, and also consistency as well. Our trained physiotherapist can help you to assess your technique and do the pelvic floor exercises. A duration of at least 4 to 6 months is advisable for your symptoms. And for patients with mild symptoms, pelvic floor exercises are effective in up to 70% in reducing your symptoms. So how do you do pelvic floor exercises? It can be performed in the sitting position, in the standing position, or lying down with your legs slightly apart. So what we would advise is you can imagine that you are trying to stop yourself from passing gas from the bowels, or try to imagine that you're trying to stop the flow of urine from the bladder. What you should be feeling is a lifting or tightening and squeezing feeling of your muscles around the vagina and anus area. So you should hold this contraction of the pelvic floor muscles, ideally for 10 seconds, and then release, rest, and repeat. And our aim is for 10 contractions per set and for 3 sets a day for at least 4 to 6 months. For the best results, you should try to focus on only tightening your pelvic floor muscles and to not tighten the muscles in your stomach area, your thighs, or your buttocks. And you should not be holding your breath while you do these exercises. It is also important to remember that you shouldn't be doing the pelvic floor exercises while you are emptying your bladder. Next, we go on to the next method of treatment, which is pessaries. So pessaries are vaginal devices that come in various shapes and sizes. In our center, we have the ring pessary as well as the gel horn pessary. You can see the ring pessary over here, and it is shaped like a ring. So these pessaries are placed inside the vagina as seen over here, and they provide a mechanical support to help to support the prolapsed organs, thus relieving your symptoms. However, pessaries require fitting by your doctor, and sometimes it may require some trial and error before we can find the best size and the best type of pessary for you. You can also still perform your daily activities with a pessary inserted. The pessaries can be used with pelvic floor exercises, and it is possible to have sex with a ring pessary in the vagina, but not with a gel horn pessary. So pessaries are most suitable for patients who are not keen for surgery or who wish to delay surgery. There are certain patients who are unfit for surgery because of other medical problems which may make surgery at high risk. And sometimes some patients also choose to use pessaries if the family is not yet complete. Some of the possible risks of a pessary may include bleeding, ulceration, or erosions in the vaginal wall. Many women also experience vaginal discharge. It may also be possible for the ring pessary to drop out with straining. Therefore, we would advise for you to come back regularly for your appointments every 4 to 6 monthly for review, and during which we will change the pessary and review for infection, erosions, or bleeding. Following a period of non-surgical treatment, sometimes surgery may be required if there's no improvement in the condition. However, having a prolapse does not mean that you definitely have to have your uterus removed. There are various types of surgeries that are available for treatment of pelvic organ prolapse, and these include reconstructive surgeries, which means repairing your pelvic floor to restore your organs to the natural position, or obliterative surgery, which means that the vaginal walls are stitched together. There are surgeries which involve removing of the womb, also known as a hysterectomy. There are also surgeries which help to preserve the womb. Surgeries can also be performed in various approaches. They can be done vaginally or abdominally with keyhole surgery. There are certain surgeries which involve the use of a mesh, but there are other surgeries which you only use your own tissues. So the type of surgery will be dependent on a few factors, and they can include your age, your medical and your surgical history, the severity of your prolapse, as well as which part of your vagina is prolapsed. It will also depend on your wishes as well. Although surgeries have a high success rate, it is also important to remember that any surgical procedure comes with risk of surgery. So we have gone through a lot about pelvic organ prolapse. So what can you do to prevent pelvic organ prolapse? Firstly, it is important to correct any modifiable risk factors which you may have, which can weaken your pelvic floor. This includes avoiding chronic constipation, avoiding heavy lifting or straining, ensuring a normal BMI, and stopping smoking. Pelvic floor exercises can also be done to strengthen your pelvic floor muscles and reduce the risk of pelvic floor disorders in the future. Lastly, if you are symptomatic, seek medical advice early. I have come to the end of my presentation. Thank you for your attention.
All right, thank you very much, Dr. Tan. So on to our next speaker. Our next speaker is Assistant Professor Park Jun-jae. He's a senior consultant in the Department of Urology, Changi General Hospital, and he's going to talk to us about the problem of overactive bladder, understanding urinary urgency in overactive bladder, and what we can do about it. Dr. Park, please.
Good morning, everybody. Thank you very much for your kind introduction, and thank you very much for coming on a Saturday to this talk. My title of my talk is Why Cannot Tahan? So local term for trying to understand the term urinary urgency. Right, so the urinary tract, as many of you will know, comprises of the kidneys, which most of us will have one each, and two ureters that goes down to the bladder, and then you pass urine from the urethra. Now, the human bladder has two functions and two functions only. One is to store urine, and the other one is to expel the urine out. Now, to store urine is done in a safe, low-pressure environment with normal bladder sensations. You know that your bladder is filling up, and you shouldn't technically have any unwanted contractions, and you shouldn't leak any urine, or we call incontinence. Also, you should be able to empty the urine when it's convenient and is socially acceptable in a very coordinated manner, empty fully or near fully. So 99% of the time, your bladder is on storage mode, and about less than 1% of the time, you will be in voiding mode. Now, to understand the bladder, this very complicated diagram is just to illustrate that the bladder is actually a very complex organ. Actually, any organs in your body is actually surprisingly quite complex, and the bladder is no different. And the brain, the spinal cord, the pelvic plexus nerves, all plays a very important part in controlling your bladder. So before I talk about when things go abnormal, particularly in urinary urgency, I want to talk about what is normal. Now, when you think of normalities, that most of us will pee, your kidneys will generate about 1.5 liters to 2.5 liters of urine per day, depending how much fluids you take throughout the day. And you will pee every 3 to 5 hours during the daytime. And that equates to about 7 times or less per day of going to the toilet to pass urine. Of course, you drink more, you pee more, and if you drink less, you will pee less. Each time you pee, the expectation is that your bladder should be able to hold at least 350 to 500 mils of urine. And it's not too uncommon for an adult to be able to hold 0.5 liter to 1 liter of urine at any given time. And just to give you kind of a perspective, how much is that? These are the rough volumes that I'm talking about. At nighttime, the expectation on a normal adult is to hold the urine overnight. You're in theory not supposed to wake up in the middle of the night. However, as you advance in age for different factors, you may go to once a night. That necessarily is not normal, but it is common. So also the other expectation is that you should be able to easily delay the need to void. Even if your bladder is full, you should be in control. Even though the bladder is full, you should be able to communicate with your bladder and tell your bladder that currently I'm too busy or I will go later. And you should be able to delay it within a reasonable time frame. minutes to half an hour, depending how full your bladder is. Also, the expectation is that you never leak urine. You're able to control the urine within your bladder until you want to pee. Now, when you want to pee, the expectation is that you should be able to easily initiate void. You don't need to strain to wait too long, and you don't have to wait too long to start urinating. You don't have to push the urine, and it should be one smooth, strong, and mostly uninterrupted flow. And you should feel like you have emptied the bladder completely or near completely. When we, as clinicians, as doctors, we talk about abnormal urine symptoms, then we give a very fancy sounding name called lower urinary tract symptoms, or LUTS or LUTS. LUTS or lower urinary tract symptoms are usually classified within these three groups. These are urinary urgency, which I will talk primarily about today, but also going to the toilet very frequently, what we call increased daytime frequency. Nocturia, when you pass urine during your sleep, you have to wake up to pass urine, and urinary incontinence, meaning that you leak urine when you don't want to. Hesitancy, straining, poor flow, intermittency when you are trying to pee. And after you pee, you may have some dribbling of the urine or this sensation of incomplete voiding. All these symptoms, when you use the term LUTS, are chronic symptoms, meaning that day in, day out, over the course of weeks, months, and years, these are the symptoms that you have, not just like a one-off event. Just to clarify, there are other symptoms such as blood in the urine, pain when you pass urine, and so on. Although these symptoms arise from the lower urinary tract, we don't call them LUTS, we just call them by the individual symptoms. Now, today's talk is primarily about this condition called overactive bladder. So what is overactive bladder? It's primarily a condition where chronically, as I said, weeks, months, years, you seem to experience urinary urgency. Urgency means that instead of you being in control, somewhat you seem that the bladder is in control of you. Like you find it very difficult to delay the need to void. And if you don't go to the toilet in time, you feel like you're going to leak urine. And some patients unfortunately do. And this is usually, but don't have to, associated with increased daytime frequency, and is usually associated, but you don't have to, associated with nocturia. So the symptom that you must have is urinary urgency. It must, however, is just by itself, you have to ensure that you have no other medical conditions that may be causing urinary urgency, for example, or urinary tract infection. So it can be either overactive OAB dry, i.e. without incontinence, or you can have the more severe form where you have incontinence as well. So it's somewhat a spectrum from mild, moderate, and severe. Moderate and severe are patients who leak urine when they have urgency before they can reach the toilet in time. It could be just a few drops. It could be a spoonful amount. It could be severe enough that your whole entire content of your bladder comes out. So, OAB incidence is quite common, about 1 in 6 of us. So if you guys go on to meet your friends and you're a group of 6 or 12 of you, 1 or 2 of you may have overactive bladder. So it's surprisingly quite common. It affects men and women as frequently. And however, one is more likely to seek healthcare advice if you are females, because women tend to have the more severe form of overactive bladder than men, those with urinary incontinence. So now I've told you that overactive bladder is a condition that causes you to have urinary urgency, even though you don't have any other underlying cause that makes you feel that way. The big question is why 1 in 6 of us have this overactive bladder. And the reality is that we don't know why. Men and women, adults who look normal, you do investigations and they are otherwise normal, they don't have any underlying condition. The brain seems to interpret this urgency instead of a normal sensation of bladder filling. So as I said earlier, the bladder is a very complex organ, and we don't know at what level, if any, is causing this sensation that you experience, this urgency sensation. It could be a problem at the brain level, spinal cord or plexus or bladder level, or it could be a combination of all of those. So we need a lot more basic science research in order to understand the exact mechanism in overactive bladder. Next, just to make it clear that there are many, overactive bladder can be a rather complicated topic where it can affect women, men, in adults, in children, even in the elderly, with other medical conditions or with neurological conditions. In today's talk, because I don't have that much time, I'll be primarily focusing in men and women with no other underlying conditions and no neurological conditions. Now, the first step is to see your GP first or your polyclinic if you have a urinary urgency that you want to be assessed. So that will be a clinical assessment and some initial investigation. So that will involve taking a history and examination, because who knows, you don't have overactive bladder, you may have something else, or you may have other concomitant conditions. And usually as a minimal standard investigation will be testing your urine, or we call a urine dipstick, make sure there is no abnormalities within the urine. And you might like to consider certain screening tests, because not many people know this, but diabetes can actually be a cause of having urinary urgency, in which case you don't have overactive bladder, you just have diabetes that is causing you this urinary urgency. A frequency volume chart, which I'll talk about in a minute, as well as an ultrasound is not strictly necessary, it's an optional test that one can consider. Now, a bladder diary is basically you pee into a measuring jug and you measure each time how much you pee and you write it down throughout the day. Usually a 3-day is a nice one in order to see your average over a course of 3 days. And then you can get all these very fancy objective data that it might be useful for your clinician. And you can also find out whether you are overproducing urine at night. Now, once you have ascertained that you have overactive bladder, you don't have any other underlying conditions, then you can go into thinking about treatment. Today's talk will be an overview of treatment rather than anything in depth, okay? So it could be all the way from conservative management, medical therapy, as well as other more advanced treatment, okay? So conservative management, it's good to communicate with patients who are having overactive bladder. Tell them that it has to be excluding other causes. Also, it's good to know that this is a chronic and benign condition, meaning that this is not cancerous, it's actually not dangerous. However, it's a long-term thing that in most patients remain stable. It may get better with time, or it may get worse in time. But it's not something that it will cause you harm, but it can affect your quality of life, depending how severe it is. It is good to set expectations of treatment outcomes, and it may take a while to find the ideal treatment for you or your loved ones. So certain advice is to avoid caffeinated drinks. We all like our coffees and teas, and most of us drinking coffee will not cause us to have much urinary urgency. However, if you have overactive bladder, drinking caffeinated drinks may exacerbate your symptoms. Avoid excess fluid intake. There is always, if you see this kind of beauty advice, or one of the beauty advices will be that to drink lots of water, which is good. Most of us actually don't drink enough. However, you may, if you drink excessively, especially if you go beyond the 2 to 3 liter mark, air-conditioned environment all day, and you have overactive bladder, that will make you pee more often. If you tend to pee before going to sleep, fluid restricting before sleep may help in some patients. The evidence is not that clear, but in patients that works, then that's good for them. If you smoke, it's good to stop smoking, because the nicotine in the cigarette smoking can affect the bladder sensation, and obesity can also make symptoms of overactive bladder worse. Other things is that if you have diabetes, then it's good to control your diabetes very strictly. It's good for your heart and your kidneys, but it prevents excessive sugar and excessive fluid getting into the urine, causing you your symptoms. There are certain medications that will actually make your symptoms worse. These SGLT2 inhibitors, such as empagliflozins and dapagliflozins, they're very good in the long term for protecting your heart and your kidneys from diabetes-related damage, but it can make your symptoms worse. Okay, and then anticholinergic medications or antimuscarinic medication. These are medications that one can take to help you with your symptoms. So they work by working in the nerve receptors in your bladder, and there are quite a few variety out there in the market. Oxybutynin, tolterodine, solifenacin. I think tolterodine and solifenacin are probably the more common one in Singapore. Oxybutynin is an older medication that is still frequently used. However, it can be a bit troublesome because you have to take them 3 times a day instead of twice a day or once a day. As a class, they can have side effects. It may cause dry mouth or constipation. Most of the time, it's not enough to make you want to stop the medication, but sometimes it can be severe enough that you don't want to take it anymore. It may cause cognitive impairment in the elderly. The evidence is kind of not very clear on that, but it may. And you have certain conditions that you cannot use them. If you have eye glaucoma, if you have constipations or colon issues, then you may not be suitable for this kind of medication, as it can make your symptoms worse. Overall compliance, meaning people keep taking it, is actually generally low. Some studies shows that about almost half of patients may not want to continue taking them. It could be because of side effects, but it could be because of unrealistic expectations on this medication. So this fancy graph, it just shows that most people, the medication will make them go to the toilet maybe once, twice per day less. So if you're going 10 times, it may reduce it by 8. Of course, some patients, it will be much more effective than others, but that's the kind of numbers that we're talking about. Likewise, if you leak urine once or twice a day, it may reduce it by perhaps 1 time less. Again, it depends. Some patients, it totally takes away the incontinence, and in some patients, it doesn't, or they decrease it by just a little bit, and they may not feel that it's worth it. Same goes for urgency and incontinence episodes due to urgency per se. So the other new medication on the block, it's been around for a few years, relatively, I guess, new to Singapore, is this other medication called mirabegron. It's still under patent protection, so the brand name is called Betmiga. And it works also in the certain bladder receptors, but it's very costly. We are talking about $3 plus per tablet per day. And so it can be quite prohibitively expensive for certain patients because it can go into the $1,000+ per year if you're on it. Side effects wise is that high blood pressure is rare but can happen. And therefore, if you have high blood pressure that is not controlled, then it's wise not to take them. In terms of effectiveness, probably similar to the other class of medication that I just mentioned, the antimuscarinic, anticholinergic class, but it's just works in a different mechanism of action and doesn't have those side effects such as dry mouth and constipation. So you can also combine them. There are now reasonably good studies to show that taking them together, especially when one of them didn't work, can be safely taken. And once those medications has been exhausted, then you might like to consider more invasive procedures. However, before considering invasive procedures, in which case you will need referral to see a urogynecologist or a urologist, is that you have to, be realistic that you have exhausted other non-medical therapy or conservative management, and also kind of be clear about what one wants to proceed with further treatment. Because if it's not bothersome, if it doesn't really bother you that much, you might not want to take this any further. And importantly, you need to see the specialist to make sure that indeed you have overactive bladder, because you may not. So let's take a standard female patient that has urinary urgency with maybe incontinence, frequency, or nocturia, and you take the initial medication, and if you respond, then you're most likely to have overactive bladder. But if it's not, then it may be undertreated, and therefore you may need further treatment, but it may be that it was not the correct diagnosis and it's something else masquerading as overactive bladder. So you may need more advanced studies, such as this thing called urodynamic studies, where men or female, either sitting or standing, is connected to these special little lines that goes into the urethra as well as into the rectum. The bladder is filled up, and then when we ask you to pee, you pee, and this measures the pressures within the bladder, and this gives us extra information about possible conditions that it means. So I won't bore you about what are the possible conditions that may happen, but there are many different conditions that it could be that be masquerading as overactive bladder when it's not. So once you have ascertained that it is indeed overactive bladder, but it doesn't, your medication doesn't seem to work well, then you may consider this other more invasive procedure, which I will talk one by one briefly. One is Botox injection. This is the same Botox as you may have injected in your face if you have wrinkles. It works by paralyzing those muscles that cause wrinkles in your face and smoothing it out. And in the same way, it also works in certain receptors in the bladder, and it kind of prevents the bladder from having unwanted sensation and unwanted contractions. And it's usually injected through this scope. This is what a flexible cystoscope looks like. And it's a bit like when people have stomach problem, you put a camera into the stomach to have a look, something like that, but much smaller, that goes into the urine passage, the urethra, and is injected in the bladder. About 80% of patients will experience improvement, okay? Probably about 50% really impressive improvement, another 30% significant improvement, acceptable improvement, but 20% it just doesn't work. They don't really see much improvement, that they are not, and they're not satisfied. But 80% is quite an impressive number. And however, you have to be cognizant that about just under 10% in studies shows that some patients, it works so well that temporarily they cannot pass urine. They are unable to pass urine, and you need a catheter to be put in order to empty the bladder. And you may have to do that 3, 4, 5 times a day regularly yourself in order to empty the bladder until the effects of Botox wears off. And so before you consider Botox, you have to be willing to accept that there is a small risk, not much, small risk, and therefore you have to be willing to do catheterization if required. The advantage is that you don't need to take any other medication. You just take Botox alone, although some patients, they need still some extra medication as well on top of that. The downside is that overall can be a bit costly, not just the medication, but the whole procedure. And just like Botox in the face, the effects of Botox will wear off. It can last you as short as 3 months or as long as 18 months. But most people, it will last them for about 9 months to 12 months is the median time that it will last. This other device is called a sacral nerve modulation, SNM, that is inserted into the lower part of your spinal cord. And it modulates, meaning that it controls the signal that goes from the bladder into the spinal cord and to your brain. And it's a 2-stage procedure. You put it first with an external battery device. And if that works well, then it would be, you go through a second operation to be inserted more permanent basis. So it kind of looks a bit like a pacemaker, and this thing has a battery inside, okay? It has the advantage that you don't have to take medication, but it's costly, invasive. The battery duration may last you a few years, and the wires that is inserted to the spine, to the nerve ending of the spinal cord may move. At this moment of time, as you can imagine, it's not very popular, especially in Singapore. People wouldn't want to have this thing inserted necessarily. And so it's not very popular in Singapore. And actually the manufacturer that bring this in couldn't really sell very well in Singapore. So for now, in 2024, it's currently not easily available in Singapore. The other option is this thing called a postural tibial nerve stimulation. There is this nerve that goes from the foot that goes to the lower part of the sacral plexus, and it shares the nerves from the bladder. So if you modulate one nerve, you can actually modulate the nerve of the bladder. So it's about 12 sessions. You go to the clinic, they inject this little needle in the nerve of the foot, and you connect it to this machine. You have a session lasting for about 30 minutes to an hour. And then you go home and you do this for about 6 to 12 sessions weekly. And then that will give you that kind of symptom improvement. And so it works by stimulating the posterior tibial nerve. It has a similar efficacy to medication. So medication works. Probably people will find about 70% of them will find improvement. And this thing also about 70% of them will find them improvement enough for them to be satisfied. So it avoids medication-related side effects because you're not really taking anything medication-wise. But it's a bit time-consuming. You have to come to the clinic once a week for 12 weeks. And then thereafter, you need some form of maintenance regime. Every few months, you should do a few more sessions to kind of keep your symptoms at bay. There is this new device called Tensine that hopefully will reach us in our Singapore show soon. And basically does something similar, but without any needles. And so you put in the ankle, and then it send electric signals by stimulating through the skin. But I suspect it's going to be pretty costly, and whether again, only for people who the urgency is very bothersome. Okay, so in summary, overactive bladder is a symptom complex, a group of symptoms characterized by urinary urgency. The exact mechanism of overactive bladder is unknown. More basic research is needed. You have to make sure to exclude and treat conditions that can also cause urinary urgency, such as diabetes. And management consists of conservative as well as pharmacological medications. And failure to improve symptoms can be referred to a urologist or urogynecologist for further investigations and treatment. Thank you very much for your time.
Thank you very much, Dr. Park. So on to our next speaker, Dr. Shamini. She's a senior consultant at the Department of Colorectal Surgery in Sengkang General Hospital. And she's here to share with us regarding bowel incontinence, a silent and hidden problem. Take it away, Dr. Shamini.
Hello, hi. Can anyone hear me? Okay. So I'm Dr. Shamini here, and I'm going to be talking about bowel incontinence, and it's always a silent and hidden problem, because most patients, I feel, always don't tend to seek help because it is embarrassing, or it's something that they feel that, oh, I'd rather just wear Pampers and sit at home. But actually, I'm here to actually raise awareness that we actually can help you. And there are ways to get your quality of life better and get control. So I work in Sengkang General Hospital, and my special interest is mostly the pelvic floor. Okay, so since we are, we have heard the, from Dr. Yinru, the womb, and then from Dr. Park is regarding the urine. So Last but not least, we're now going to talk about the back passage. Yeah. So what is fecal incontinence? Okay, so basically it is an inability to control the bowel, and it results in involuntary passage of stools. And unfortunately, the prevalence of it is about 18% and in the population, but somehow in Singapore, the prevalence is very low. And I feel that it's not that it's actually low in Singapore, but I think most likely what has happened is that people are not coming forward to tell people that I have problems controlling my bowels, and instead they just, as I said, they hide in their symptoms, and that's why the prevalence of reporting is low. I wouldn't think that Singapore is actually low. I would think that it's actually much, much higher than what is counted. So just like any other condition, there are two kinds of incontinence. One is urge, and then one is passive. Urge means is that, oh my goodness, you feel that there's some stools coming through you, and then you quickly need to go and run. Just like urine. Okay, so the incontinence is almost similar, just like one is urine, one is bowel. So urge means you feel like you want to go and you need to run. Some people will tell me that, oh, doctor, I only can hold on for only 30 seconds or only for 1 minute. Because if I do not get to the toilet as soon as possible, I will leak. Okay, so that's the typical symptomology or history for people with urge. When it comes to passive means, oh, I'm doing something and you're doing your walking or you're doing other things, and then you don't realize that something has passed until you feel something wet or you feel a smell. Then you go and check and like, oh my goodness, I've already have a bowel movement. So that is passive incontinence. So that's the difference lah, okay? Okay. So like any other incontinence, what causes it? Why am I having this problem? And most patients, when they come to me, they're like wondering, why am I having this problem? So there are various factors that maintains your continence. So number one, you need to have a rectum is your back passage. It's like a reservoir. It's like a storage system. So it needs to have a decent sensation and compliance. That means if there's stool in there, it needs to expand. And then when there is, and of course, the sensation for you to go lah, okay? So in fecal incontinence, your rectum, your reservoir that keeps all your stools becomes very sensitive. So a little bit of a stool sitting there, you feel that you need to run. And there are many factors as to why this has happened. It could be because there are some patients who had radiotherapy in the past or had surgery or which they've removed the back passage. So the area is becoming very sensitive. Or maybe they got a lot of inflammation around the back passage. So that also can cause the sensation to be very sensitive. So every time the bit to go in, they have to run. And sometimes it can be compliance. That means it's very stiff. Again, sometimes if you receive radiotherapy, also can cause this problem. Now, the other thing is muscle damage. So unfortunately, this is number one for women lah, okay? So unfortunately, we go through pregnancy and then we go through childbirth. And then when the baby comes out, sometimes you have tears, and it is quite common to have tears. Not all tears will cause this problem, but sometimes can be a very big tear, and of which the anal muscle gets damaged. So when the anal muscle gets damaged, and that's when you are of a higher risk of developing this issue. Now, not to say that everybody who got anal problems will have this issue. It's just that it just gives you a higher risk. And of course, there are patients who go through any surgeries down the anus. One most common is the removing of hemorrhoids. Okay, so unfortunately, removing of hemorrhoids surgery, there is a small risk that some muscle has been taken away during the hemorrhoid surgery, and then you may not get any symptoms immediately, but it may be when you are older, then this condition can get you. That's why when you see the surgeon sometimes for your hemorrhoids, we don't tend to give you surgery all the time. Just because you have hemorrhoids doesn't mean you have to remove them. You have to earn your surgery, let's put it this way, because if you have a lot of surgery done in your bottom, the risk of this damage goes up. And of course, you can have nerve damage or neurological. So some people who got spinal cord problems or they got stroke, sometimes even people with Parkinson's and things like that. So basically, your neurological symptoms are not very clear or not very good. Even people with diabetes as well, because your neurological system also gets affected with diabetes. So all these affects also the pelvic floor, because you also need your nerve system. Your nerve system also gets impulses from the brain to tell you what to do, okay? So when that doesn't flow very well, then you can get incontinence, all right? Then, of course, there's medication. So let's say your thyroid medication, your diabetic medication. So some medication that you take that makes your motion very loose also can give you incontinence. So let's put it this way, even if you have a very good back passage, you've got very good muscles, let's put it this way, if all of us got loose stools, you also cannot control our bowels. So that's why medication is something that we always go through very thoroughly so that we can modify your medication accordingly. Then, of course, the general weakness of your pelvic floor muscle. That one is secondary to aging. So as we get older, our muscle also not as strong. That's why things like Kegel exercises or any exercises that develop your core and pelvic floor is very, very important. That's why when, especially those women who have just delivered, all your doctors always say you must do your exercises. It's because the more you maintain your pelvic floor, the longer it will function. And then just like how we exercise in the gym, same symptoms. Same principle. You will regain your mobility, and also the purpose of the muscle will also prolong. Okay. And also, okay, constipation is another thing. Okay, I know it's a bit of an opposite thing. Like, oh, I thought incontinence only happens to people who cannot control, but there are people who are very, very constipated. So when you are very, very constipated, what will happen is your body will try to loosen the stools because it needs to evacuate. So suddenly you have a lot of loose stools coming out, but actually you're just very constipated. So these are one of the things that we also look at, and all you have to do is get the bowels working, and sometimes that is all you needed to be done to solve the problem. So that's what it is. So that's why when you come to see the doctors, we assess you in all fronts. So the consultation is always never short. We should take our time to look and ask all these questions, because there's a lot of factors that can be predisposing you to the current condition that you're having. So what we do is when a patient comes in with fecal incontinence, we do a very thorough history. We can have a good chat. We look at your diet. We look at your medication, your medical history, and see, because and all that, and also your bowel habit, any surgeries that you've done in the past, how many babies you had, are they big babies, how many tears you have. So these are the things that we will go through. And of course, the main thing that we also look at is the impact of the quality of life. Because some people may only have one episode and then that's it. They never had it anymore. And they'll say, oh, I only have one episode, but now I'm completely fine. And the last time I had was 6 months ago. So, they may not need as much intervention from us, but there may be one patient that come to me and say, oh my God, doctor, every day I'm leaking. Every day I got stools, I have to wear Pampers, I can't leave my house, I always need to be near the toilet. And that's it. I'm housebound, and you're an active person, but you can't leave the house because you're just too scared to do anything. You can't take public transport. You can't take anything. So these people are very heavily impacted. So in this way, there are things that we can do to help you. And of course, we examine you. So we look at your tummy, and usually we look at your bottom. And just by looking at your bottom, sometimes it gives us answers as to what is going on down there. And then if you do not have a bowel evaluation, we always do a colonoscopy. I think it's very important that this is done. So don't be alarmed that, wow, I come with incontinence. Why is the doctor looking at my colon? It's actually very, very important, because unfortunately, cancer can also cause these symptoms. So it's our job as doctors to make sure that that's not the case. And once we clear the colon by doing a colonoscopy, then we can concentrate on the other things. Fecal incontinence itself is actually most likely benign, but it's very, very important that we exclude the organic causes. Then, of course, we look at, as you say, your toilet access, your medication, and other medical problems that causes loose bowel motion. So we look through all that, and then most of the time, it's something that we can tweak. We will tweak it. Okay. So just a little slide to talk about what colonoscopy is all about. Some of you may have already gone through it, okay? It is a very good tool to look at the colon. It's definitely better than any scans out there because we can actually look at the lining of the colon, and then if there's any like tumor or any like polyps, we can actually remove the polyp if it's there, and then we can send it to the lab, and then we can look through to see what kind of polyp we're dealing with or what kind of cancer we're dealing with. But it's definitely a very, very good test to do. It is done by IV sedation. It's a very fast test. It only lasts about 15 to 30 minutes. But you're usually in hospital about 2 to 3 days because 2 to 3 hours, 2 to 3 hours, because it's a day procedure. So you do not need to stay overnight at all. Definitely can be claimed by MediSave and any insurance company because of that, because you have symptoms. And then, but the most difficult part that usually patients tend to complain about is the bowel preparation. Not the scope itself, but actually the bowel preparation. Because unfortunately, for us to look at the lining of the colon, you have to take the bowel preparation, and that means you have to drink like almost 4 liters of fluid, and that will make you go to the toilet. So the night before, you suffer a little bit. You go to the toilet about 7 to 10 times to evacuate. Then the procedure itself is usually relatively okay. Of course, there's a small risk of making a hole in the colon, but that happens in 1 in 1,000 cases. Okay, so unfortunately not zero, but very, very low risk. Okay, but of course there are some patients who can't go undergo this kind of test, or maybe there are some patients who are very scared because they feel it's very invasive. So there are other conditions or other ways that we can do it. So what we have is a special CT scan that can look at the colon. They'll put air in your back passage, and then they do a CT scan. Barium animal is something that we don't do anymore. It's something that was done maybe 50 years ago, but it's not that we don't do it anymore, this kind of test. So most of the time, those people who can't do colonoscopy, we will do a CT colonography. Okay, so now, as I said, you are now in a specialist clinic. We've gone through all the history. We examined you. So what do we do? Okay, so I think pretty much, as I say, we will go through your goals. Okay, so for example, just say you tell me that you have incontinence for like 3 times a week. So I can say, okay, maybe I can improve it to say, once a week. Okay, so unfortunately, these kind of symptoms cannot be totally taken away. You can't be like, okay, I want to be 100% better. It is more like trying to make it a bit better so that you can maybe go out for short periods of time. So it's all about management of expectations, okay? Because sometimes, no matter how much help that we give, we cannot 100% take away the said symptom, but definitely we can make it better. So what do we do? So what I would tend to tell you in the clinic is I would tell you how to eat. So there's sometimes you got to do some dietary modification and how you actually live your life. So most of the counseling is mostly that. Like for example, you do not want your stools to be very, very soft, because if you always have soft stools and it looks like mud and then or a bit watery, and that's always been your normal stool, you can't have that because your pelvic floor is now getting quite weak. So my purpose now is to make your stools a little bit more formed, like a banana, like to have some form of shape, because that will give you time to look for the toilet. Even though I extend your time from 30 seconds to 5 minutes, it will make a big difference, because at 5 minutes, luckily you're in Singapore, there's always a decent toilet that you can find somewhere around the corner, okay? And that's pretty much what I do. So things like, you can't take too much tea and coffee, things like that, because it actually makes your gut go very quickly. So any food that makes your gut go very fast, I will have to stop that. So things like chilies, curries. Sometimes some people are very sensitive to dairy products. So like, milk, yogurt. We just have, not to say you can't have it at all, but what I'm trying to say is more of moderation or even cutting it down. So usually when it comes to caffeine, you only just make it to 1 cup, okay, a day. Because some people tell me, oh, I must have my coffee a day because I cannot wake up. So that's fine, but you can't take like 3-4 cups, okay, during the day, because that would just make you go. And then, as I said, okay, and then certain fruits like papaya and things like that makes you go, we have to stop, okay? So certain things we just have to avoid. and then modify, and sometimes that's all that's required. And then we will tell you how to take care of your skin, because if you're going to the toilet many times, you got incontinence, unfortunately the skin gets excruciated as well. So we will tell you how to take care, putting some creams, and of course we give you some pads and things like that to wear, especially when you're going out. Now, medication-wise, so there are a few medication that we can give. So don't be alarmed when we give you things like fibrogel. Then you look at the packet, but it's for constipation. I don't have constipation. That's not what it is. Okay, the fibrogel, what it does is it gives you shape. It makes your stool big. All right. So when the stool is bigger, as I said, it gives you more time. And then not only that, it doesn't give you loose stools. So that's what I'm trying to do. And loperamide is an antidiarrheal pill. So instead of going like 4 or 5 times a day, hopefully you only go once a day. So that kind of control. So hopefully with this supportive management, most of the time we can get it better. Okay. So, but sometimes, even despite all this, people still got say, oh, you doctor, I try all this, I follow all your advice, I'm still in this situation. What's the next step? Okay, so what do we do? So that's when we do specialized tests, okay, because that will give us more answers as to what's going on in your pelvic floor. And that usually requires 2 tests. One is a manometry, it's called the balloon test, to see what's the pressures between your abdomen and your anus, and also an ultrasound to look at the muscles of the anus. Because especially among women, when we have tests, is to make sure that the muscles are intact. Then depending on this assessment, usually the most common intervention that we do is biofeedback. It's basically a range of exercises that we will tell you how to do to strengthen the muscles. So, and then usually my specialist nurses, they are the ones that will go through the steps with you. And the main thing is you have to do this exercise. A lot of patients are very poorly compliant. They will learn it very nicely in the clinic, but then when they go home, they don't practice. You have to do this every day. Every day. And even though it's only like 10 times in the morning, 10 times at night, it makes a big difference. Most patients, when they just do this thing, at least 70% will get better just by purely exercise. Okay, so and they do. Only if those 30% they don't tend to get better, then they need surgery. Okay, and there are some surgical options that we have there. And you will see that there's some overlap from the urine point of view as well. So these are all overlaps that, because we all are dealing with the same compartment. Okay, so this is the specialist investigations that I told you about, the manometry. I know it's very colorful and all that stuff, okay? It's just to tell you that, okay, if you look at something that's very red and orange, that means the patient has activated the muscle. If you're very strong, the muscle will be very good. It should be red color, okay? If it is green or only yellow, that means very weak. So you see in the with very good pressure, we ask you to squeeze. Wow, I can see that all red. That means very good. That means you got very good power. But those who, wow, I ask you to squeeze, you say, okay, make sure you don't want to go toilet, you squeeze, but then everything all green color, then that means I know your pelvic floor is very weak. Okay, so pretty much it gives me a lot of answers as to what is going on when you are doing the squeezing in front of me. Okay, so usually my nurse will be the one doing it, all right. And this is the ultrasound that I go to. I know it looks very long there, but actually only a little bit goes in, okay? Don't get alarmed with this. And it just looks at the muscle. So if you look at the picture on your left, it needs to look like 2 rings, okay? So our muscle has got 2 rings, okay? One is called the external and the internal. So these 2 muscles must coordinate with each other so that it gives you continence, all right? So it needs to be complete, like a ring. But unfortunately with tests, like the one on the right side, you can see there's a defect from the 10 o'clock all the right out to 2 o'clock. That means there is a defect at the front here. That means it's no more a circle anymore. It's a U shape, all right? So of course, just like anything, when there's a U shape, there's a gap there, you try to squeeze your bottom, it will be, it will not work as well, all right? So this ultrasound gives me answers as to what we're going to do. And then this is the biofeedback. Okay, so I have this machine in my hospital. It's like a little monkey carrying a banana. So when you squeeze your anus, the monkey will go up and catch the banana on the top. Okay, so you can, it's like it tells you that what your muscles is doing now. Okay, so it's like a little game that you play, and then it gives you exercises. So my nurse will do this so that you know what to do, and then it tells you, okay, this is the muscle that I need to activate, because you'll be quite surprised, especially when the muscles are very weak. Sometimes when you tell people to squeeze the muscle, you don't know which muscle. Am I doing the right thing? Is it the bottom? Is it here? Am I doing correctly? So the purpose of this session is to actually guide you that you are doing the right thing at the right time lah. All right. Okay, so just like Dr. Park has mentioned, you saw this battery in his talk. It's called the sacral nerve stimulation, and it actually can also deal with the fecal incontinence. It's actually got a lot of good data out there that it actually makes a lot of difference, especially those who suffer from passive incontinence. Okay, so unfortunately, it's a very big unfortunate is that it's not covered by MediSave, and unfortunately you have to pay for the battery. So hence it's very, very expensive. And that's why the uptake of this treatment, even though it's pretty good, is not very common. I think one battery sits about 10,000, I think, from what I last heard. And the battery life is only about 5 to 8 years. So you could imagine after 5 to 8 years, then the battery needs to be changed, then you need to conjure up another 10,000. So it's a very expensive tool, especially for anyone to pay this kind of money, and hence why the uptake is pretty low. So what it does is it has like wires, okay, which we will install at the back, okay, of your bottom. I mean, you know where your bum is at the top there. So that's where the battery sits. And then these wires are going to give some impulse to the sacral nerves, which is the nerves that's at your back there in your sacrum. And then that leads towards your pelvic floor, and that helps with the contraction. As well as, and because all nerves goes down to the pelvis, it also works both the bladder as well as the anal muscle as well. Okay, so that's what it does. And then the other thing that we also do, remember I told you about the gap that was found in the ultrasound. So what we can do also is that if there's a gap in the muscle, we try to stitch it close, okay? So it's also quite a good operation to do for those who have tears, all right? But unfortunately, it cannot last very long. So even though immediately after the operation, you find that, oh, wow, I can control my bowel. But then as about 5 years to 10 years, what tends to happen, the function then tends to go down in the sense that, oh, you know, I'm not controlling it as well. And that's just the nature of it. So that's why even after an operation like this, we still continue with the biofeedback. Okay, so that even though it's intact, doesn't mean you're lazy. Yeah, must go and continue with the exercise so that your function is prolonged. Okay, that's pretty much what we do. Okay, now another thing that I want to talk very briefly about is rectal prolapse. Okay, this is another thing that also can come with fecal incontinence. That means a bit of the bowel is sticking out. That's because the pelvic floor is so loose, is so lax that the entire, not the entire, but the rectum can just come down. Just like how the womb can come down, the back passage also can come down. Okay, so some you will notice like maybe, oh my God, why is this lump coming here? Now it is difficult to discern what is what. I know in layman's terms, we think, is it a hemorrhoid or is it what? But if it's usually quite big, it can be the whole rectum prolapsing bomb. And when we see these things, we usually repair it, okay? Because when you don't repair this, it's very hard to control bowels now, okay? When part of your bowel is sticking out like that. So what do is we do this in the keyhole setting, all right? So this is the womb, okay? And then usually the colon sits behind it. The rectum comes beside it. So we put a little mesh, all right? And then to hike it up, just like how we hike up the womb or hike up the bladder, same principles, we hike up the large bowel. So when you hike up the back passage, and everything all comes back to its normal anatomy. And then, only then, we will do a bit of biofeedback, okay? So usually we tend to repair first before we proceed to the pelvic floor exercises. This is another technique that we do from the bottom. So this is from the abdomen. This is from the bottom. So what we do is we will kind of cut away the excess lining of the bowel and then stitch it up. Okay, so pretty much it's a much safer operation than the abdomen, but unfortunately, it comes back quite frequently. So that's why on fitter patients, we tend to do it through the abdomen. But if it is an elderly, let's say 90-year-old, very frail, we can usually do it from the bottom. Okay, so what's my conclusion? This is my last slide. So I'm going to say help is available. Okay, so please don't hide. Please don't be embarrassed. Please seek your GP about this. And then there's always help, in India, in hospitals that offer pelvic floor service. There's always something that we can do for you. Okay, if you do suffer from this. And sometimes it's only just a simple trick of medication and some exercises. Most of these symptoms can get better. All right. So please don't suffer in silence. And then please don't feel that, oh, my colonoscopy is clear. So you know what? No problem. Just let me sit in peace lah. Okay, leave me alone. So it doesn't mean no problem, because at the end of the day, in this day and age, it is quality of life that we are trying to offer you here. Okay. That we don't want you to be sitting at home and being housebound. We want you to be going up and about and doing and getting back your life back, and not be ruled by these symptoms. Okay, and that's and here I end my talk. Thank you.
Thank you, Dr. Shamini. That was an extremely engaging talk. And on to our very last, but not the least speaker, Dr. Julia Yatim. She is our beloved Assistant Director of Nursing in the Singapore General Hospital and an expert in managing the pelvic floor. She will talk to us about pelvic floor matters, myths, facts, and solutions. Dr. Julia, please.
Thanks, Dr. Sherilyn. Can you hear me? Okay, my name is Julia. My patients call me Sister Ju. So I am sharing with all of you today an awareness about pelvic floor matters, myths, facts, and solution. All right. So this topic is very important, and being the last speaker, I'm sure you have heard all the best topic from all the specialists. I'm just creating an awareness for all of us here, and this is the content of my slides. Let me take you through the basics first. Pelvic floor, which is a group of muscles resembling a hammock that supports the bladder, bowel, and uterus, and it's very crucial in maintaining our core stability and facilitating various bodily functions. So it has been shared just now. It looks like a hammock, and its job is very important. Let's go through myth 1. The pelvic floor is only relevant to women. Contrary to popular belief, the pelvic floor is not exclusive to women. While it is true that pregnancy, childbirth, and menopause can significantly impact the pelvic floor in women, men also have pelvic floor muscles that are essential for urinary and bowel control, sexual function, and overall pelvic support. From a wide lens, the pelvic floor sits three-dimensionally within the pelvis. You can see through the picture here, but no muscles were in isolation. Myth 2. Pelvic floor disorders only affects older adults. Well, pelvic floor disorders can affect individuals of all age, you or me, not just older adults. Factors such as pregnancy, childbirth, obesity, chronic constipation, and certain medical conditions can contribute to pelvic floor issues in people with varying ages. So it is essential to recognize the signs and symptoms of pelvic floor dysfunction and seek appropriate care regardless of age. Myth 3. Kegel exercises are the only solution for pelvic floor problems. While just now we have the specialist talking about Kegel exercises, these can be beneficial for strengthening the pelvic floor muscles. They are not the only solution for pelvic floor problems. Depending on the specific issues, Other treatment options vary, and sometimes surgery may be necessary. So it is crucial to consult with a healthcare professional to determine the most appropriate treatment plan. Myth 4. Pelvic floor disorder is normal after childbirth. This is not entirely true. While pelvic floor changes are common during pregnancy and childbirth, experiencing dysfunction such as urinary incontinence or pelvic organ prolapse is not inevitable or normal. This misconception often leads to underreporting and delayed treatment, so it is essential to raise awareness that help is available. Myth 5. Pelvic floor exercises are only for women who have given birth. Pelvic floor exercises, including Kegels, are beneficial for all individuals as it strengthens your core muscles. This exercise can help prevent and manage various pelvic floor issues that have been mentioned earlier. Myth 6. Pelvic floor disorder only affects urinary and bowel control. While urinary and bowel control issues are common symptoms of pelvic floor dysfunction, they are not the only manifestations. This dysfunction can also lead to pelvic pain, sexual dysfunction, pelvic organ prolapse, and discomfort during daily activities. Addressing these symptoms comprehensively requires a holistic approach and considering all aspects of pelvic floor health. Myth 7. Pelvic floor dysfunction is untreatable. This is a treatable condition, and many individuals experience significant improvement with the right interventions. Treatment approaches may vary depending on the specific symptoms and underlying cases, but include pelvic floor physical therapy, dietary modifications, behavioral strategies, and sometimes medication or surgery. So you can seek early intervention, and working with the healthcare professionals specializing in pelvic health can improve your outcome and quality of life. The last myth, myth 8, pelvic floor health is irrelevant unless symptoms are present. Contrary to popular belief, pelvic floor health is relevant for everyone, regardless of whether symptoms are present. Just as we prioritize cardiovascular or musculoskeletal health through exercise and preventive care, maintaining pelvic floor health is essential. And practicing good bowel and bladder habits, seeking regular checkups can all contribute to optimal pelvic floor function to prevent further issues. So why does the pelvic floor matter? Because all bladder and bowel functions need good pelvic floor muscles. For example, when you need to go to toilet, you use your pelvic floor muscles to prevent any leaks. Then you will fully relax them to pass urine when you physically get to the toilet. Strong pelvic floor muscle boosts your core strength and stability. So physical therapy is vital in treating all aspects of pelvic floor disorders. It is an individualized program that acts as the first line of treatment. So what are the solutions? If you have any of the signs or symptoms as mentioned by the specialist earlier on, seeing a continence physiotherapist or specialist nurse is essential. The trained personnel will be able to identify the root cause of the hypertonicity and provide tools to help overcome this. The treatment session may involve a combination of the following. You receive patient education, learning how the pelvic floor functions and how to keep it healthy can help you develop better good habits. Pelvic floor exercises, simple exercises that can strengthen and stretch your pelvic floor muscles. Pelvic floor manotherapy. This is internal massage that may be used to promote circulation, posture, and flexibility. Biofeedback, as mentioned by Dr. Shamini, this can help you gain greater awareness of your pelvic floor muscles. So it may take a few months of physical therapy sessions to notice symptom improvements, but most people do eventually notice a difference. I will not dwell through on a simple pelvic floor exercise because Dr. Tan has gone through comprehensively, but I would like to emphasize that while you are doing the exercise, these are important points to note. You do not hold your breath, do not push down instead of squeezing and lifting up, not to tighten your tummy or buttocks, or the release things simply of just letting go. Don't force the release. You think of softening. You can do the exercises during daily routines such as showering, brushing teeth, after urinating while in toilet. Very little should move when you're doing pelvic floor exercise apart from pelvic floor itself. Remember, you need to be trained for this. Don't start this yourself if you're not confident of where is the muscles that you need to work on. Now, there is some benefits of pelvic floor exercise for men. Let's switch our attention to men. Many factors can weaken the pelvic floor muscles for men, including the surgical removal of the prostate and conditions such as diabetes and overactive bladder. You might benefit from doing the pelvic floor exercises if you have urinary or fecal incontinence, dribble after urination, that is usually after you have left the toilet. For pelvic floor manual therapy, this is can be done in the clinic, as I do perform this as I'm a trained personnel. This internal trigger point massage of the pelvic floor can sometimes be helpful for tight pelvic floor muscles. This purpose can reach further into all the pelvic muscles with ease. And through this physical examination and treatment, the therapist can identify tightness and tenderness and gently stretch the connecting muscle. For the patient, comprehensive counseling and patient commitment is required. So what does pelvic floor physical therapy entail? When it comes to pelvic floor physical therapy, it is important to be consistent to achieve good results. Some people need months of physical therapy to find relief for their symptoms, and in some cases, maintenance therapy is needed to prevent issues from coming back. Pelvic floor physical therapy can reduce a myriad of symptoms caused by pelvic floor disorders, ranging from incontinence to chronic pain and sexual dysfunction. So if you suspect that you may be experiencing pelvic floor dysfunction, discuss your symptoms with your doctor to determine the best course of action for you. Some practical tips that you can take away. You need to have a healthy and fiber-rich diet full of fresh whole food, staying well hydrated, reducing caffeine and carbonated drinks. This has been mentioned by Dr. Park. Relieving yourself of urine and stool when needed rather than holding it. Practicing good genital hygiene. You can maintain a healthy weight and taking steps to ensure proper posture, including exercise, strength training. Reduce stress and of course, to find out what triggers your symptoms, which can cause further insults to your pelvic floor disorder. Very often, we meet complex presentation among our patients, and we need to demonstrate the importance of a thorough assessment, as problems in the pelvis are often not isolated. Here, I'm sharing on the pelvic floors. Flaw is the lack of knowledge. Flaw is faulty movement patterns developed throughout life. Flaw is accepting incorrect exercise advice. Flaw is believing problems can be fixed by surgery while continuing damaging habits. Here we are. Pelvic Floor Disorder Center is a seamless multidisciplinary service that aims to provide holistic and integrated care by experts in the fields. As an advanced practitioner in this service, I provide direct care through consultation, advice, and education. I provide evidence-based practice and often make ethical decision-making, and also collaborate with other stakeholders. So for you, if you wish to contact us at SingHealth Duke NUS Pelvic Disorder Center, which is an integrated multidisciplinary clinical practice and services for pelvic floor disorders, the specialists are from these hospitals as stated here. You can contact us through management via Help by the app as shown here. And these are the useful resources. With that, I thank you for your kind attention. Thank you.
Thank you very much, Dr. Julia, for sharing what you know about management of the pelvic floor. So on to our last segment, which is often a favorite segment for our listeners, which is the question and answer section. So perhaps we can start with questions for Dr. Tan first. Dr. Tan, take it away. So question number 1 from the audience was, does pelvic organ prolapse occur in men? And why is it more common in women? Dr. Tan, please.
The pelvic organ prolapse talk which I was giving was referring to female pelvic organ prolapse, whereby the pelvic organs bulge into the vagina. And prolapse is definitely more common in women because of the female anatomy, as well as with pregnancy and childbirth. However, men do have pelvic floors, so as mentioned by sister just now. And rectal prolapse, which was covered by Dr. Shamini, can also occur in men.
And probably also to add, it's more common in women, not only because of the anatomy, but also contributed by childbirth, as well as menopause that happens only in women. So childbirth and menopause can contribute to a weakness because of a loss of hormones and because of the stretch of the pelvic floor after giving birth. So for more details, obviously, you should seek help from your pelvic floor specialist or your gynecologist. So on to our next question for Dr. Tan. Does jumping, Pilates, and trampoline exercises cause pelvic organ prolapse? Something that a lot of people engage in. Dr. Tan?
Yes. So exercises which are high impact, such as jumping, and I assume that trampoline exercises also involve a lot of jumping. These can actually put a lot of pressure on the pelvic floor. So this could increase the risk of pelvic organ prolapse. There are many different types of exercises in Pilates itself. So if certain exercises in Pilates can help to strengthen the pelvic floor, but sometimes, of course, if you are doing a lot of straining or like high impact jumping, then that can also cause more pressure on the pelvic floor and increase the risk of pelvic organ prolapse. But there are also other risk factors. So just doing jumping alone, I think, may not directly cause you to have a prolapse. Yeah.
Okay, that's great. And to our last question for Dr. Tan, how fast after a cesarean section can I start Kegel exercises? Maybe Dr. Tan can share not just a cesarean section, how about a normal vaginal delivery? How long after that can a lady start Kegel exercises, Dr. Tan?
Yeah, so in fact, after cesarean section, as long as you are not in a lot of pain, you have minimal pain, and your urine catheter, your urine tube has been removed, there is no specific duration that you have to rest and not do Kegels exercises. So you can start Kegels exercises as long as your pain is well controlled and you feel ready. Because Kegels exercises is an exercise of the pelvic floor muscles, but it's important that after cesarean section that you avoid straining or putting any pressure on the near the cesarean section scar. For normal delivery, actually, for some patients with a deeper tear down below, okay, sometimes after the repair, while the patient is still in the hospital, we can also refer to the physiotherapist to teach you how to do the pelvic floor exercises. You may not have to do them immediately, but at least you learn how to do them. And when you are ready and when the swelling and the pain has improved, you can start your Kegels exercises.
That's great. Sorry, one more question for Dr. Tan. She's a bit popular today. Is there any disadvantage in doing Kegel exercises lying down instead of upright? Very interesting question.
I would say that you can do the Kegels exercises lying down or sitting upright or standing, whichever you feel that you prefer. However, some patients may actually feel that doing the Kegels exercises lying down may be a bit easier for them. So maybe beginners can start with doing lying down. But if you feel like doing them sitting up or standing, that's perfectly fine as well.
Okay, thank you, Dr. Tan. And on
Thank
to our
you.
next speaker, Professor Park. All right, so Professor Park is going to be quite popular today. He's got loads of questions, but we only have time for 5. So first question is, does prostate surgery contribute to pelvic organ prolapse and incontinence? Dr. Park?
Thank you. Sorry, I've been trying to answer as many questions as possible. I can't type fast enough. So your question of, does prostate surgery contribute to pelvic organ prolapse and incontinence? It's a bit of a nuanced question because there are 2 broad kind of prostate surgery. You could be talking about benign prostatic hyperplasia, where you have an enlarged prostate and you do a surgery such as TURP or transurethral resection of the prostate, where you remove the part of the prostate that's causing obstruction. Or you could be talking about radical surgery for prostate cancer, where the whole prostate is removed. Either way, in men, you can get rectal prolapse, but you wouldn't get the kind of pelvic organ prolapse of a uterus coming out of the vagina, because men doesn't have that vaginal opening. So to answer your question, men don't get pelvic organ prolapse like the women unless it's a rectal prolapse. But incontinence it can happen after prostate surgery, especially prostate cancer surgery. So if you are bothered by this, I suggest that you get an assessment by the urologist who treated you for your prostate.
All right, so next question. After laughing, sneezing, maybe walking too long, jumping, I leak urine. So what actual condition is this?
Yes, this is called a stress urinary incontinence, or SUI. Is stress not in the sense of a psychological stressor, but when you put too much pressure in your abdomen, it squeezes on the bladder. And if you have a weak pelvic floor or a weak sphincter of your urethra, then you may leak urine when you don't want to. And so again, it's a condition that is separate to overactive bladder related urgency urinary incontinence, but it's actually quite common for women to have both. And so when you have both of these, we call it mixed urinary incontinence. And so you might, if this is bothering you, then you might like to consider an assessment.
All right, next question. Is waking up many times a night to pass urine, is it normal? Is that considered an overactive bladder? Is it something else?
Yes, I've been getting a lot of questions about this nocturia, and where it's a condition where you wake up in the middle of your sleep in order to pee, and then you go back to sleep, and then you wake up again and you go back to pee, and then you go back to sleep. So each of those is a nocturia episode. Is technically not normal, meaning that you're not supposed to have that. Your kidneys, quote unquote, goes to sleep when you go to sleep. And therefore, your kidney will concentrate the urine so that it produces less volume of a urine. And that's why for most of us, when we first wake up in the morning and we pass urine, the urine looks so yellow because it's a very concentrated urine. And overall, for older adults, if the amount of urine that you produce during your sleep hours is about 1/3 of your total urine volume, but for a very long list of conditions, you may produce way more urine during your sleeping hours than you will otherwise would, and that makes you go to the toilet very often. So where you have overproduction of urine at night, it can be strange conditions such as congestive heart failure with leg swellings. It could be due to obstructive sleep apnea with snoring at night. It can also be problems related to your bladder ability to store urine overnight. So whether it's overactive bladder or enlarged prostate in men. So as you can see, it's not so easy to answer this question. In short, it's not normal, but once or twice as one grows older might be acceptable and nothing that you need to do. But when it starts hitting 3 or 4 times a night, most people will find it very bothersome, and therefore you need a full assessment to see what is your cause of the nocturia and see what can help.
Okay, next question. Is there any association between the overactive bladder and heavy lifting?
In short, no. Or heavy liftings can, if you have prolapse or stress urinary incontinence, it can make it worse. Other conditions with heavy lifting is inguinal hernias, more common in men than women. Varicocele in men, where they have dilated veins in the scrotum, can all be made worse by heavy lifting, but not with overactive bladder. But again, you may have unfortunate to have both conditions, overactive bladder as well as stress urinary incontinence, And in that case, heavy lifting will make it worse.
Okay, and last question for Dr. Park. Does holding back urine, like not going to the toilet when you need to, does it cause urinary incontinence? Does it make it worse?
Yeah, so again, it's not a straightforward thing to answer. By and large, holding your urine and going to the toilet when you want to go later is safe, okay? So it's actually also part of this thing called bladder training, where you hold, if you have overactive bladder, make sure you have an assessment, you don't have any underlying condition, you are told that you have overactive bladder. You can slowly train your bladder to you don't be so dependent on what the bladder says to you. Instead, you trying to take your control back. So you feel like passing urine every half an hour, say, instead of immediately going, you remember that Dr. Park said that it's okay to hold your urine, is safe, and you kind of delay for 5 minutes, you kind of focus on something like for 5 minutes, and then you go. You do that consistently for about a week. You'll find that, hey, holding back for 5 minutes is easy for me, and you can push it to 10 minutes. So with this kind of bladder training, you may push the ability to perhaps go every hourly instead of every half hourly, or every 2.5 hourly instead of every 1.5 hourly. And it's not perfect, but you may have a more reasonable time frame. Now, I say this with a bit of caution because there are some patients, although rare, that they don't like to use public toilets. So they will pee in the morning before they go to school or to work, and then they will just hold the urine all the way until they come back to home. And that's such an unnecessary excessive holding of urine is bad. That can damage the bladder, and that once you damage your bladder, it may cause incontinence. So excessively holding out unnecessarily, that's bad. But if you have been assessed already, you are found to have overactive bladder, you don't have any other underlying cause, and you want to do this kind of bladder training gradually with or without medication, avoiding caffeinated drink and so on, that's a good thing for you.
All right, thank you very much, Dr. Park, for answering all these questions. And on to our next speaker for the bowel incontinence segment, Dr. Shamini, Professor Shamini. First question. My father has stool on his underwear every day, and he seems to be unaware of this. But he only passes stools once every 2 to 3 days. So is this normal?
Hi. So if you look back to my previous slides, sometimes fecal impaction can also come with what we call overflow incontinence, in the sense that they are passing loose stools even though they're only passing, every, let's say, 1 to 2 to 3 days. It could be that your father may not be evacuating his stools as efficiently as he think. Actually, opening your bowels once every 2 to 3 days is considered still in the normal range, but maybe for him it may be that slightly on inefficient manner. However, it is not normal for him to have stools in his underwear of which he is unaware, and if he doesn't have his colon evaluated yet, then I would suggest that he should see a specialist, and definitely he should get at least a colonoscopy just to make sure that everything is all well and good. And then we can address, after which, if it's all clear, then we can address his bowel motion, regulate it a bit better, and then take it from there.
All right. So for the next question, how do we differentiate between a pelvic floor problem and irritable bowel syndrome? Because both of these conditions seem fairly common.
Yes. It's not just common, there's also a slight overlap as well. So one can exacerbate the other. So irritable bowel syndrome is a whole spectrum of symptoms. So such as bloatedness, abdominal cramping, either constipation or diarrhea. So this is, and it comes in a different kind of spectrums depending on what kind of, are you mostly the diarrhea kind of person or the constipation kind of person. But they tend to get associated with other abdominal symptoms like cramps and bloatedness. So, but pelvic floor issue is, for when it comes to the bowel, is mostly unable to control. So it'll be mostly incontinence in the sense that you find staining, or you have to run to the, you cannot control your bowel, because if not, you will have an accident. So that is pretty much a pelvic floor issue. So you can see that these are the two different conditions. However, I have patients who have irritable bowel syndrome, especially those on the diarrhea side. So that means they already are going to the toilet already a few times. And if their stools are not controlled, then they can have and that will cause their pelvic floor issue, in the sense that they can't, because the stools are so loose that they have accidents. So because maybe their pelvic floor also is not that great, and then on top of that, they have a loose stool, so it doesn't help lah. So one problem causes another. I mean, not say causes, but pushes a problem to get to come to the forefront. So, but there are two separate issues. One doesn't cause the other, but definitely one problem can make the other problem worse. So at the end of the day, for you to find out whether you have one or the other, because sometimes I know it's a bit confusing, it's best to go to your polyclinic or see the doctor. And what our job is to make sure that you do not have any organic causes. So usually what your doctor would do is make sure you have an endoscopy. So either a OGD or a colonoscopy, just to make sure everything is clear. Once it is clear, then by symptomology, they will treat one or the other. So if you have irritable bowel syndrome with diarrhea predominant, they will try to control your diarrhea, okay? And usually if your diarrhea predominant is controlled and your pelvic floor is okay, you should be fine. But if your pelvic floor is weak, it's very important that your diarrhea is better controlled by the gastroenterologist, okay? So either one or the other, do seek help, and then we can, it's a case-by-case basis, we will go through it individually and find a right treatment for you.
All right. And for the last question for Dr. Shamini, will regular jogging and exercise, does it help with incontinence, both urinary and bowel incontinence?
Right. Okay. So the kind of exercise that we are talking about is pelvic floor exercises. So pelvic floor exercises are a very distinctive set of exercises that only works on the pelvic floor. So unfortunately, things like jogging or jumping or certain upper body work or weightlifting, all that doesn't really work on the pelvic floor. Of course, jogging is good to work on your limbs and some of your core muscles and things like that, but not necessarily the pelvic floor. So it doesn't really help with the incontinence. But of course, jogging is very good in your general health, because it's very important that we maintain your cardiovascular health in the long run. So when it comes to incontinence, so you have the specialist nurses. What they will do is they will teach you what are the pelvic floor exercises that you need to do. And then from then on, that will work on the pelvic floor, and that would actually help with your incontinence.
All right. Thank you very much, Dr. Shamini. And for our last speaker, Dr. Julia, who is our pelvic floor nurse. So as a patient, I've been told that I would benefit from all these pelvic floor exercises, Kegel exercises, etc. But where can I find these exercises? Who's going to teach me? Is there any avenue that I can go to? Dr. Julia, can you share with us and the audience?
Okay, thanks, Dr. Fu. Well, there are many social media platforms, especially YouTube, where pelvic floor exercises can be followed. But however, in order for you to get access to us, is number one is to get referral, because this is very true, because you may not know all the underreporting symptoms that you may portray or you may have. So in our restructured platforms, in our restructured hospitals, so once the specialist has seen the patient will be referred to either the continence physiotherapists or the specialist nurses. And this is when we will comprehensively perform assessment and also plan for your regime of how good a pelvic floor exercise that can be done for you, customized, and also follow up on the outcome of your symptoms improvement. So in summary, in our hospital basis, that it needs to be referred in However, I do have some of my clients before that, patients before that, that went through this in private physiotherapy centers, which can also be done if you wish to do so lah. Right, Dr. Fu.
All right, thank you very much, Dr. Juriash, for sharing. So, using this QR code to send in your feedback about the Zoom webinar, let us know whether or not you found this useful. We are going to try to aim to have this yearly, as a yearly pelvic floor public webinar, so that we can refresh and talk about different topics every year. You can also share with us what are the other topics that you might want to hear on your future public forums or public webinars. Next slide, please. So without further ado, let us draw a close to this public webinar. And here are all the speakers. In summary, how to find us is you can see our SingHealth institutions, Singapore General Hospital, KK Hospital, Changi General Hospital, and Sengkang Hospital, all have pelvic floor surgeons in their respective departments. If you have any issues, you can always get referrals to each of us in the SGH, that means Singapore General Hospital, and in the KK Children's and Women's Hospital. We also have a combined pelvic floor clinic that you can ask your GP or your polyclinic doctor to refer to if you have some pelvic floor issues that need to be sorted out by a specialist. So without further ado, thank you everybody. Thank you all the participants. Thank you all the speakers, our hosts, and we hope that you have a great Saturday ahead. And please take care of your pelvic floor. Signing off. Thank you.